Opening. Hello and welcome to today's podcast. My name is Nomang, and today we're exploring a topic that sits at the intersection of culture, society, and compassionate healthcare. This episode asks a simple but powerful question. How can cultural competence transform end-of-life care and reduce health inequalities for older Chinese migrants in Australia? By the end of this episode, you'll understand how society and culture shape health and healthcare access, to major models of cultural competence, how these models apply to real-world health inequalities, and what culturally competent communication looks like in practice, including a story from hospice care. Let's begin. Section 1. Society, Culture, and Health Inequality. To understand health inequality among older Chinese migrants, we need to look beyond disease and into the social determinants of health. These include income, education, work conditions, language, and social support. IHW 2022. Language and health literacy. Many older Chinese migrants have limited English proficiency. This affects their ability to understand medical information, navigate referrals, or use telehealth. These barriers reduce confidence and delay care. Katri and Asifa 2022. Social isolation. Migration often disrupts long-standing social networks. During COVID-19, older Chinese migrants reported increased loneliness, anxiety, and poor chronic disease management. Et al. 2023. Work and economic pressures. Many Chinese migrants work in low-paid, physically demanding jobs. Even when they understand health advice, they may not have the time, money, or job. Flexibility to act on it. AHW 2024. Cultural expectations. Family-based caregiving is common in Chinese culture. Older adults may rely heavily on children for appointments and translation, which can create stress for carers and reduce autonomy. Et al. 2023. These factors show that health inequality is not about individual choices. It is shaped by structural and cultural forces. Section 2. Two models of cultural competence. To address these inequalities, health organizations increasingly turn to cultural competence. Model 1. Campinhaba Coates Model. This model describes cultural competence as a continuous process involving cultural awareness, cultural knowledge, cultural skill, cultural encounters, cultural desire. It emphasizes self-reflection and ongoing learning. For Chinese migrants, this means understanding the role of family in decision-making, cultural beliefs about aging and illness, communication preferences. However, this model focuses mainly on individual clinicians, not the system around them. Model 2. Cultural Competence Continuum Cross et al. This model describes organizational stages from cultural destructiveness to cultural proficiency. It highlights policies, workforce training, service design, community partnerships. This model is powerful because it recognizes that health inequalities are systemic, not just interpersonal. Applying the models. Both models show that cultural competence improves communication, trust, and engagement. But they also reveal limitations. Cultural competence alone cannot fix income inequality, job insecurity, or structural racism. Section 3A. Story. What good culturally competent VAD care looks like? Let me tell you a story. Mr. Lee, a 67-year-old Chinese-speaking kitchen hand who has lived in Australia for more than 30 years. He's worked long shifts in hot restaurant kitchens, often 6 days a week. Like many migrants, he put his family first and his health last. Now in hospice care with an advanced terminal illness, he's facing decisions no one wants to face. A good voluntary assisted dying VAD process for someone like Mr. Lee begins long before any paperwork. It starts with trust. His care team arranges a Mandarin-speaking interpreter not just for translation, but to ensure he feels heard in his own language. They explain the VAD pathway slowly, checking understanding, and making space for questions. Language barriers can create fear and withdrawal from care. Ketri and Asifa, 2022. They also recognize the cultural context. In many Chinese families, talking about death is taboo and decisions are often collective. The team asks Mr. Lee who he wants involved. He chooses his daughter. The clinicians gently shift the translation burden away from her because good practice means family support without family pressure. Mr. Lee shares that he doesn't want to suffer or burden his family. He wants dignity. He wants peace. He wants control. These themes are common among older Chinese migrants navigating end-of-life care. Xi et al., 2023. Throughout the process, the hospice team ensures clear, bilingual communication, respect for cultural beliefs, private space for family discussion, psychosocial and spiritual support. In the final days, the hospice environment is calm. His favorite Chinese music plays softly. His daughter holds his hand. Staff speak gently, using simple language, honoring his preferences. Whether or not he proceeds with VAD, the process is safe, respectful, culturally attuned, and centered on dignity. This is what culturally competent care looks like. Section 3B, Story 2, Mr. Lee's family through Campaign Habakkuk's model. Let me share another part of Mr. Lee's story, this time from his family's perspective. When Mr. Lee entered hospice care, his daughter, Maimei, carried a quiet heaviness. She had been translating for him since she was 7. Every appointment, every form, every difficult conversation. She never complained, but the weight of being both daughter and interpreter had shaped her entire adult life. A culturally competent team begins with cultural awareness. They recognize that Maimei's exhaustion wasn't just emotional, it was cultural labor. She has been carrying the weight since she was a child. The kind of burden many migrant children silently carry for years and years. The team understood that in many Chinese families, children are expected to protect their parents from unwanted bad news. So when Mr. Lee's condition worsened, Maimei struggled. She wanted to be honest, but she also wanted to shield him. This tension is deeply rooted in filial piety, the belief that children must preserve their parents' dignity and peace. The clinicians used cultural skill by gently separating medical communication from family roles. They brought in a professional Mandarin interpreter, allowing Mei to step back into the role she longed for, simply being her father's daughter. Through repeated cultural encounters, the team learned how to communicate in ways that honored the family's values. They asked permission before discussing sensitive topics. They checked who should be present. They allowed silence, something often misunderstood in Western care, but deeply meaningful in Chinese communication. And finally, there was cultural desire, the genuine willingness to understand, not just accommodate. One nurse noticed that Mei always brought homemade soup, a traditional gesture of care. So she arranged a quiet space where Mei could feed her father without interruption. It was a small act, but it restored dignity to both of them. As Mr. Lee's condition declined, Maimei told the team, "I just want him to feel respected. He worked so hard his whole life. He deserves peace and calm now." This is the heart of cultural competence. Not just knowledge, not just training, but the willingness to see a family's grief through their cultural lens and to respond with compassion that honors who they are. Section 4. Applying cultural competence to a real intervention. Let's connect this story to a real-world intervention, the Multicultural Health Navigators program. These bilingual navigators help migrants understand medical information, book appointments, navigate referrals, manage chronic disease, connect with community groups. Why it works. Using Campaign Habakkuk's model, navigators bring cultural knowledge and skills. They build trust through repeated encounters. They demonstrate cultural desire, using the cultural competence continuum. The program shifts organizations toward cultural responsiveness. It strengthens community partnerships, evidence, Research shows bilingual navigation improves trust, health literacy, and service uptake. Khatri and Asifa, 2022. For older Chinese migrants, it reduces reliance on family and supports more. Independent Chronic Disease Management Z et al., 2023. Limitations: programs are often small-scale. They rely on specific staff. They don't address deeper structural determinants. Still, they are one of the most effective culturally competent strategies we have. Section 5. Health Promotion Communication Strategies. To promote cultural competence, organizations need communication strategies that are linguistically accessible, culturally meaningful, and community-driven. 1. Multilingual, plain language communication. Information must be simple, visual, and available in Mandarin and Cantonese. Huff and Klein, 2017. 2. Community-based storytelling. Stories reduce stigma and make health messages relatable. 3. Partnerships with Chinese community organizations. These groups provide cultural safety and trusted access points. 4. Today we explored how society and culture shape health inequalities for older Chinese migrants in Australia. And when we talk about end-of-life care, we often imagine a system that treats everyone equally. But the truth is, it doesn't. Not when it comes to spiritual care, and especially not for older Chinese migrants. Let me tell you more about Mai Mei. Her father is in a public hospital. He's a quiet man, a migrant who worked long hours, paid taxes, raised his family, and never asked much from the system. He doesn't belong to any religion. Like many older Chinese migrants, his spirituality is cultural, grounded in family, duty, harmony, and the unspoken rituals around death and dying. But when Mai Mei looks around the hospital system, she sees something confronting. Most of the spiritual care services are built for Christian patients, not because anyone is trying to exclude others, but because the entire structure of spiritual care in Australia grew out of Christian institutions, especially Catholic hospitals, which still dominate palliative care. So when Mai Mei asks for spiritual support for her father, what she gets offered is prayer. Christian prayer. Delivered with kindness, yes, but not with cultural relevance. And for a family that doesn't identify with Christianity, it feels like the system is saying, your kind of spirituality doesn't fit here. This is where inequality becomes visible. Public hospitals, the ones serving low-income migrant communities, are underfunded. They have fewer spiritual care practitioners, and the practitioners they do have are rarely trained in non-religious or East Asian cultural models of meaning-making. So Mai Mei's father faces a double disadvantage. He's in a public hospital with limited spiritual care staffing, and he's non-Christian in a system designed around Christian norms. This isn't just a service gap. It's a form of cultural exclusion. Because non-faith doesn't mean no spiritual needs. It means the needs look different. For many Chinese migrants, spirituality is expressed through family harmony, ancestor respect, unspoken fears about death, guilt, duty, and unfinished business, the desire for a peaceful transition. But none of this is captured when the hospital record simply says religion, none. And here's the deeper issue. The people who need culturally safe spiritual care the most are the ones least likely to receive it. Wealthier families can choose private hospitals or pay for external support. But working-class migrants, like Mai Mei's family, rely on the public system. And that system is struggling. Fewer staff, less training, almost no bilingual practitioners, and no funding for roles that understand Chinese cultural frameworks around dying. So Mai Mei sits by her father's bedside, feeling something she can't quite name. It's not anger, it's not blame, it's the quiet ache of being unseen. The sense that the system wasn't built with families like hers in mind. And that is the inequality at the heart of this story. Not dramatic, not loud, but deeply felt. A spiritual care system shaped by Christian history. Underfunded in the public sector, and not designed for the cultural and existential needs of older Chinese migrants. This is where equity work begins, by noticing who the system fits and who it quietly leaves behind. The key message is this: cultural competence is essential for equitable healthcare, but it must be paired with structural change and community partnership. As we close, I want to leave you with a few questions. What does dignity look like for someone whose first language isn't English? How do we honor a lifetime of sacrifice from migrants like Mr. Lee, who built our restaurants, our hospitals, our cities often unseen? And perhaps the most important question: if we were in their position, what kind of care would we hope someone offered us? These are not just policy questions. They are human questions. They ask us to look inward at our systems, our assumptions, and our capacity for compassion. Thank you for joining me on today's podcast. I'm Nameng, and I hope this conversation not only informs you, but moves you toward a future where every person, in every culture, is met with understanding, respect, and the dignity they deserve.